So this is the first sort of my dedication to my team. This is our mission statement. And you'll see that in this slide, I actually have two bookends. One is we do complex interventions in the human heart. And the other extreme, you see that it's bookended by basic science. These are all my colleagues, physicians, physician scientists, clinicians who do the work. And it's a great privilege for me to be a part of that team. And I'd also like to have a brief shout out for some of the, our funding sources. So bulk of our research, of course, comes from tax dollars, as you can see. This is, in this presentation, you'll see some of your tax dollars at work. So how, dramatic is this field? The biggest challenge in mission in cardiology is the fact that 34 people die every minute in this world because of cardiovascular problems, of which 22 people die suddenly. So it is staggering. So when you think of this number, it's 12 million deaths per year globally. And just think about it, right? We had lunch and we came back. And in that 1 hour, thousands of people have died. So, and the challenge of sudden death is also shown in this slide very beautifully, because we spend most of our time as cardiologists, people in this audience, we're taking care of people with severe heart disease, depressed ventricular function. And as a slice of patients in that group, there is about a quarter of them who are going to die suddenly. But when you look at the risk of sudden death, the actual number of people who are dying suddenly, that is shown in this shaded part of the circle. And it actually involves a lot of people who have minimal heart disease and some people who have no heart disease. So that is a challenge. And why do they die? They die because of this arrhythmia. They die because of VTVF. And we now know that one big driver of VTVF is changes in the myocardium, especially changes in repolarization in neurotransmitters. And this, of course, is a big focus of science. And it's also the big focus of interventions, electrophysiologic interventions we use in the heart to prevent sudden death. So diving into this topic, I thought we'll first talk about catheter ablation of VT as a sort of a starting point, and then we'll end up with device therapy. So let's take a patient who you're likely to see later today in your clinic or tomorrow. 52-year-old female, monomorphic PVCs, cardiomyopathy, but no evidence of a scar on an MRI. So when you see this patient, when you see a patient who has PVCs and has a low EF, we now know that this is a reversible cause of cardiomyopathy. You don't have to put them on ACE inhibitors and beta blockers for life. You can actually ablate and treat them. And so this is the kind of the pathway of management that we recently put together in a review article in the New England Journal. So when you have patients who have PVCs or structurally normal heart when they have VTs, you can actually place a catheter in their heart, and right this minute there's a case going on. I just talked to your EP team over here who are good friends of ours. So this is happening this minute right here in this hospital. So we can actually map and ablate these PVCs. And these areas, based on looking at the surface ECG, we can precisely localize where these arrhythmias come from. And using some of the most sophisticated interventional techniques, we can map and ablate these locations. And this has a huge impact, and it's had a huge impact in clinical practice. The next aspect of practice is also that no matter where a PVC comes from in the heart, we are developing more and more tools to get there. Here's an example of the fact that we map all within the coronary arteries and veins. And in one of my responsibilities at UCLA is I get to oversee and interact with the cath group and the cath program. So when you talk to the interventionalists, and you're going to hear from the talented interventionalists over here, that they do a lot of work on chronic total occlusion and so forth. And so we were inspired by that work, and we actually interacted with our neuro interventional colleagues. And nowadays, when you actually have VTs that come from within the myocardial wall, so this is a culprit over here, we can actually place wires within the perforating coronary arterial vessels, and you can deliver a small coil and embolize that branch. So this is kind of a precise ablation, which is guided by an electrical recording from within the myocardial wall. So this is intra-coronary arterial embolization to ablate VT. But then, what do you do if your VT actually comes from an area where there is no coronary artery or vein? And that's the point where we actually use the Stingray system, which is a chronic total occlusion system that interventional cardiologists use for opening up chronic total occlusions. And so you can actually place a wire within the coronary artery, dissect out of the vessel, and enter the myocardial wall. And in this case, this is a close-up showing you how the wire comes through this specially designed balloon. It perforates outside the coronary artery here, and it gets into the myocardial wall, and you can get a recording from that, and you can actually ablate that region of the heart. So catheter ablation is getting to be very sophisticated, and there is a sort of a synergy and a blending of two fields, if you will, because where does interventional cardiology end and where EP begins? It's all one interventional field. And of course, in very rare cases, if this doesn't work, we actually do intraoperative mapping and ablation. So intraoperative mapping is making a comeback. Now, people with structural heart disease are a much bigger challenge in the world of EP and in cardiology. And these patients, of course, require very special care and very aggressive care. So now let me show you a patient here. This is a 56-year-old male, non-ischemic cardiomyopathy, EF of 30, presence in VT storm, incessant VT. And this is not an uncommon referral that complex EP programs get at places like Mount Sinai and at UCLA. And so this patient's battery was dead because the patient got so many shocks and is now getting external shocks. So these patients obviously are in a state of almost PTSD because of the extreme shocks that they've received. And of course, how do you manage these patients? So it's worth spending a second talking about what drives arrhythmias. Here is a confocal image of the heart showing a myocardial infarct and areas of viable myocardium that is within the scar. And these areas of abnormal electrical propagation interact with nerves shown over here, which is a neuronal stain of the heart. And one of the discoveries we made is the heart is densely innervated. So this interplay of structure and function is what creates the circuits for ventricular tachycardia, which of course in an EP lab, you can place catheters and map out the areas that are controlling these arrhythmias. And it's not only that, you can actually display where there is a scar and which area is normal using computer mapping systems shown over here. So this is a color 3D display of the location of the scar and normal myocardium. And these areas of abnormal electrical propagation shown in this panel is where the electrical impulses sort of meander through and complete a circuit of VT, which is shown in this panel. Now, the big advance in the field of VT ablation is the patient doesn't have to stay in VT for you to ablate VT. You can actually ablate that when the heart is in normal sinus rhythm. So during sinus rhythm, if you carefully place catheters inside the heart and you look for areas of abnormal electrical activation shown over here, these are the areas which can actually sustain or are responsible for slow conduction, which is the abnormal electrical pathway. And these areas can be identified in sinus rhythm, and you can ablate them because these are the sort of the abnormal electrical pathways through which impulses propagate, responsible, which cause VT. And of course, during VT, if the blood pressure is stable enough, you can actually map and terminate VT. But if a patient has hemodynamically unstable VT, that's not a problem. Map in sinus rhythm, get rid of all these late potentials, and the patient becomes non-inducible, and you can control VTs. Now, VT ablation has had a huge positive impact on patient care. And as it turns out, this is, if you look at the literature in the past 15 years, all the top AP academic programs and large clinical programs in this country have set up very specialized programs to manage VT, and mainly because it is a life-saving intervention. So multiple innovations have occurred over the years. This is epicardial mapping and ablation. Mount Sinai is a very famous place for cardiac imaging. And one area of imaging is nowadays if patients have pacemakers or defibrillators, we still can get an MRI in them safely, and not just get an MRI. We can actually see the heart. As you can see in the panel on the left, there is an artifact because of the implanted device, but you can make these artifacts go away by using a special technique, which is called wideband MRI. And of course, this is something that has had another major positive impact in the field because it goes beyond catheter ablation, right? So if you have a patient who's you're evaluating for any heart disease, you can now get a very good MRI of their heart, and you won't have a problem of interference from the implanted device and these artifacts. Now, this is a slide worth pausing for a second, and what it shows is this is the first large multi-center database, the IBTCC database that was put together. It has data from all the top centers in the world that do VT ablation, and we approached all these sites to actually collate this data. And for the first time in over 2,000 patients, we were amazed by the impact of VT on mortality. So patients in whom you couldn't control the VT, the mortality was awful. It's almost like some cancers. So there's a 30% 1 year mortality, per year mortality, if someone has sustained VT in the presence of structural heart disease. Therefore, VT ablation is life-saving, and the curve over here is these are the patients whose VT recurrence was prevented by catheter ablation, and you can see that this has had a dramatic impact on mortality, and you can see multiple groups contributed to this. This panel in the middle over here, this is Jacob Korath, Vivek Reddy, and Srini Dukipati from right here in Mount Sinai. So we are all very passionate about this procedure because it works in patients with ischemic cardiomyopathy, irrespective of your EF. Look at that. These are patients with very low EFs. Dramatic difference. What about non-ischemics? Doesn't matter whether your EF is more than 30 or less than 30. In fact, sicker the patient, the benefit is even greater. Doesn't matter what is your NYHA class, 1, 2, 3, or 4. No difference whatsoever. Every single group benefits. So VT should be sought and controlled. And you simply cannot ignore VT because it has a powerful impact on the patient's outcome and mortality. And many of these patients actually have reasonably good EF, so there's no reason why they should be on poisonous antiarrhythmic drugs or be sent to cardiac transplantation when that heart can continue to work well for them for the next several decades. And when you look at all the published studies in the literature, which I've put together in this table, you'll see that it consistently shows that catheter ablation of VT is life-saving. So it is well worth being very aggressive. It's a long procedure. Don't get me wrong, it's very hard on the teams that do this. These procedures take 4 to 6 hours, but every one of these cases, it's life-saving. So you're going to see a lot more in the next few years, and hopefully in your future meetings at the symposium, you're going to see more papers that are going to come out that's going to further expand and bring this treatment to a greater number of patients. Currently, we are just operating on the sickest of the sick patients, and a lot of patients are being left untreated. And with the improvements in catheter technologies and reduction in procedure times, we hope someday, much like angioplasty and so forth, we'll be able to move this treatment and expand it to a larger group of patients. Now, moving to the next component of this, again, point to remember, 30% 1 year mortality or need for transplant if you have sustained VT or episodes of VT. So VT has to be controlled. So what about extremely sick patients? Patients who have had previous cardiac surgery, patients who are so sick that they're in cardiogenic shock when they're transferred in. No worries. These patients can also be mapped and ablated, and this is a multi-center experience which was collated from multiple centers around the world, including UCLA and Mount Sinai. We can put in assist devices, impeller devices during catheter ablation. In patients who have previous cardiac surgery, we actually can do hybrid procedures in the cath lab. So this is data that a series of papers that came out of our group, and the Brigham and Women's has also published this, where we surgically open the chest in the EP lab, and you can map and ablate. Therefore, previous cardiac surgery doesn't prevent or preclude catheter ablation because of the fact that there are adhesions in the chest and the EP's electrical circuits may be on the outside of the heart. And you also notice that in this slide, we've put in patients who have VADs. So transplant cardiologists, just because they have a VAD, doesn't always fix the problem, because if people have VTs with a VAD in place, that really depresses their cardiac output. And so this is another ever expanding need for catheter ablation in patients who already have ventricular assist devices. So what about patients, after doing everything with catheter ablation, we've done everything, intramural mapping, and they still have VT. All hope is not lost yet. So if you have extremely refractory VT that cannot be controlled with catheter-based techniques, start thinking differently. Think one level above. Go beyond the heart. So this is another major thrust, and in the past decade, we started doing this first at UCLA, but now many other centers have replicated this experience, where we actually work with our thoracic surgeons, and we surgically, using video-assisted thoracic surgery, we surgically remove half the stellate ganglion all the way down to T4. So you cut the sympathetic chain on both sides, and now this is history repeats itself. 100 years ago, this was the procedure that was used for angina, before we knew there was something called cardiac catheterization, long before we were able to do bypass and cardiac surgery and angioplasty. So this is how angina was controlled, and now it's come back to control VTVF. So cardiac sympathectomy is life-saving. And as it turns out, when we look at a international experience, we actually recently published this, and for those of you in the audience, Dr. Fuster gave a very wonderful presentation, a commentary on this paper when it appeared in JACC. And Dr. Fuster, of course, again pointed out that this is life-saving, and you can actually do this procedure without much surgical side effects. Some patients have hemothorax, but the incidence of Horner's and those old complications that you have with sympathectomy is extremely low. So again, reason for a lot of hope, and really to bring these treatments to patients. Completing the entire circle, if you will, we now have done cardiac sympathectomy in 3 patients at UCLA with refractory angina who were waiting for a heart transplant because there was nothing that could be revascularized, complex coronary lesions, tiny vessel disease. And 3 patients have been taken off the transplant list after doing cardiac sympathectomy. And these patients are back to a completely normal life and taking very minimal anti-anginals. And these were patients who used to take a bag of medications a day and were still suffering with incapacitating angina. So it's fascinating, and this entire area of neural control is a big area of research focus for us. Now, what about patients who already have severe heart failure and are struggling because of heart failure? And that's one area where electrophysiologists are called to implant defibrillators to prevent VTVF, just to shock them out of VTVF and, of course, hopefully control VT. But what is new in the area of heart failure, and as this audience knows extremely well, with worsening ventricular function, survival comes down, and this is, the typical progress of heart failure. And this has been powerfully impacted by medical therapies, beta blockers, ACE inhibitors, but also by having device therapies. And several years ago, Dr. Brownwald and Dr. Narula had us put together a very interesting atlas of electrophysiology and heart failure. And when we actually collated this data, it's again points out that there are many, many electrical problems, atrial fibrillation, need for ICDs, need for cardiac resynchronization devices in these patients, all of which is life-saving. And in fact, you can see an entire book was edited just to deal with this issue. So what is kind of very fascinating, if you look at the entire heart failure literature from the view and the perspective of an electrophysiologist, this is data that came from a drug that actually didn't work, besnarenone. But when you looked at survival of these patients in the trial and just looked at their QRS duration, it just shows the wider your QRS, the worse your outcome was. So this sort of planted the seed for really understanding the role of cardiac resynchronization and really trying to understand electrical propagation in the heart. And what the entire field, and as actually is a great example of collaboration between heart failure specialists and electrophysiologists, and doing a series of studies over the past 3 decades, we've actually shown that first and foremost, you can put an ICD to prevent someone from dying suddenly. But then, when patients have a left bundle branch block and left bundle conduction delay, as shown over here, there is a complete reorganization of the ventricle. There are metabolic changes. The heart does not contract effectively, and its pressure volume loop, of course, becomes completely ineffective. So the heart as a pump can be improved by taking someone who has left bundle and putting in a cardiac resynchronization device. And the way this was accomplished was by threading wires into the coronary veins and making the QRS narrow. Now, what has made a sort of interesting comeback in our field is, again, history repeating itself. And this is going back to the work of Tawara, the man who discovered the AV node. And Tawara actually was the first person in the history of cardiology to show that the atria connect to the ventricles, especially the His-Purkinje system. The electrical impulses goes through the AV node, which goes through the central fibrous body of the heart. This was kind of a major advance in the field. And we now know that this, viewed from the left side, the His-Purkinje system, the left bundle, which comes into the LV and activates the greater portion of the LV, can actually be accessed by interventional techniques. So an old idea is making a comeback. And when you look at cardiac activation in normal and in the presence of a left bundle branch conduction delay of various types, it can be proximal, mid, or distal or arborization blocks. In all these conditions, the ineffective contraction of the ventricle can be sort of resynchronized by searching for the His signal, which of course occurs in your surface ECG during the silent portion, the PR interval, right? So if you place a catheter in the heart right here near the membranous septum and you map the patient, you will actually see the His signal shown over here, which is where the His bundle pierces the central fibrous body shown here in yellow. And this region is a region where you can actually place an electrode and pace the heart. And this is a very powerful way of achieving cardiac resynchronization by using the heart's own wiring system. So instead of having to thread a wire into the coronary veins, which goes to the lateral LV wall, you can actually use the free way of electrical propagation of the heart itself. And to do that, all you have to do is map the location of the His signal and put in a pacing lead in that location. And as it turns out, this is a focus of a lot of work. And looking at these color images over here of normal and left bundle conduction delay, all these areas, all the reds in this image, those regions that are late activated can actually be improved by His bundle pacing. And this His bundle pacing, of course, no matter what the type or the reason for left bundle conduction delay, whether it's SCAR or diffuse cardiomyopathy, it seems to have a beneficial effect. And this is a big area of ongoing prospective trials. And so here's an example of a patient with EF15. All was done was a single lead over here. You can see that this is the His bundle pacing lead, and it dramatically improves EF. So we don't yet have prospective randomized data to say that His bundle pacing is going to replace CRT, but it's a hot topic of investigation. And we as EPs completely love it because it's less hardware in the heart. So I think keep tuned to this. You're going to see a lot more data come out. And I'll also leave you with one last thought. In your clinic, in patients who already have CRT devices, if many of them are having PVCs, that is preventing them from getting full benefits of resynchronization, catheter ablation still has a role, where if you actually ablate those PVCs, and this is data, again, multi-center collaborative data that shows that if you ablate those PVCs, you can actually improve and give them the full benefit of cardiac resynchronization. And I'll finally leave you with the thought that there is a lot of basic science that's ongoing, and we are now really understanding mechanisms of arrhythmias by going back to understand some of the points I made in this talk, such as electrical propagation in the heart and the nervous system of the heart. And this slide has been put up just to show you how delicate and elegant the heart is. There's not a single heart muscle cell that does not have a nerve that runs next to it. And we think that the next generation of interventions, in fact, all of heart failure treatment is actually dealing with what the nervous system does, right? Neuroendocrine activation. So there's going to be an entire generation of procedures that are being designed for the heart, and not just the heart, it goes beyond the heart because the nervous system connects all parts of the body, and we refer to it as the internet of the human body. So you're going to see a lot of therapies that are going to come up that is going to be neuroscience-based therapies, and the heart is no exception to that. So I'll stop here. Thank Professor Sharma, Dr. Narula, and Dr. Kinney, and the faculty here at Mount Sinai, Dr. Fuster, for this honor and the opportunity to talk to all of you. Thank you so much.